When a neonate presents with Potter sequence, pulmonary hypoplasia, and massively enlarged hyperechoic kidneys, the clinical picture appears absolute. We are looking at a macroscopic landscape where aggressive, fluid-filled cysts are physically displacing healthy renal tissue. Historically, this specific neonatal presentation triggered an immediate clinical assumption: autosomal recessive polycystic kidney disease, or ARPKD, caused by a mutation in the PKHD1 gene. However, systematic genetic screening has revealed a discrepancy. Up to 20% of patients who exhibit this exact renal morphology carry no mutations in the PKHD1 gene. This means ultrasound imaging, while effective at showing the damage, is incapable of identifying the cause. It masks a spectrum of diverse, genetically distinct ciliopathies that only appear identical on a screen. Resolving this diagnostic mirage requires a move past visual morphology and into the mechanics of the primary cilium and the evolving KDIGO pharmacological guidelines. Because different genetic defects follow different clinical trajectories, the ultrasound is only the starting point of a much deeper molecular deduction. The primary vertebrate cilium is a mechanosensory organelle governed by proteins at the transition zone. On the membrane, polycystin 1 and 2 regulate calcium channels. Below, fibrocystin facilitates signaling. In ARPKD, PKHD1 mutations truncate fibrocystin, breaking these critical pathways. When this microscopic signaling fails, it triggers systemic ductal plate malformation and initiates the rapid, uncontrolled growth of renal cysts. This is why cystic kidney disease is defined by a signaling failure at the cilium, where the macroscopic growth we see on a scan is the final result of a microscopic mechanical breakdown. But because the ciliary network involves so many proteins, mutations in entirely different genes can produce a phenocopy, a separate genetic defect resulting in the exact same clinical appearance as ARPKD. This pedigree chart illustrates common phenocopies. Left, unaffected parents pass hypomorphic PKD1 alleles, causing early-onset ADPKD, visually identical to ARPKD. Right, a spontaneous de novo mutation appears, accounting for nearly 20% of ADPKD cases. The DZIP1L mutation is a separate defect that perfectly mimics the ARPKD phenotype, despite the PKHD1 gene remaining completely normal. DZIP1L is responsible for maintaining the transition zone's diffusion barrier. When mutated, the barrier fails, physically preventing polycystin proteins from entering the cilium and halting the signaling process. Another critical phenocopy is the HNF1B microdeletion, a systemic disorder where renal cysts are frequently accompanied by severe neurodevelopmental disorders. Because this involves a deletion at the 17q12 genomic locus, these patients require systemic management plans. This includes neurological and endocrine monitoring, needs that wouldn't be identified if the clinician only looked at the kidneys. Identifying specific genetic drivers is the only way to anticipate extrarenal complications and metabolic risks that define a patient's long-term clinical course. As cysts dilate, the kidney's macroscopic rhopicacture is destroyed. Healthy, filtering nephrons are compressed and eventually replaced by dead interstitial fibrosis. This chart tracks that decline through the estimated glomerular filtration rate, or eGFR. As the nephrons fail, the eGFR enters a downward trajectory, crossing into the clinical thresholds of stages 4 and 5 chronic kidney disease. At this stage, the kidneys can no longer clear phosphorus from the blood, leading to the first major metabolic crisis, hyperphosphatemia. This model shows the secondary effect. As phosphorus levels rise, the body actively leaches calcium from the skeletal system to compensate, causing significant bone pain and vascular damage. Simultaneously, potassium homeostasis breaks down. High blood potassium is an acute threat that can trigger fatal cardiac arrhythmias if not strictly managed. These failures make protein intake a critical variable. It must be strictly titrated to prevent the buildup of toxic uremic waste. The stage 4-5 target is roughly 90 grams of primarily plant-based protein per day, preventing muscle wasting while minimizing the uremic load. Metabolic management in advanced CKD requires a precise balance. A failure to control phosphorus, potassium, and protein simultaneously accelerates systemic organ failure. Historically, management at this stage was limited to diet and strict blood pressure control. However, new pharmacological tools have changed the standard of care. The 2024 and 2026 KDIGO guideline updates integrate therapies specifically designed to alter the biological timeline of renal decline. These updates extend the use of therapies previously reserved for diabetic nephropathy to the broader population of non-diabetic CKD patients. Returning to the eGFR graph, SGLT2 inhibitors flatten the downward slope. Adding GLP-1 receptor agonists provides further stability. Finally, NSMRAs cumulatively stabilize renal function while reducing cardiovascular risk, buying significant time before end-stage failure. By reducing inflammation and protecting the remaining nephrons, these combined therapies represent a move toward the active preservation of kidney function. Following updated KDIGO guidelines is the primary method for actively slowing the biological progression of the disease, rather than simply managing its symptoms. The neonatal cystic kidney is a downstream symptom, a structural manifestation of a breakdown in the ciliary signaling network. Because so many different genes can cause the same structural collapse, testing only for PKHD1 leaves 20% of the diagnostic picture incomplete. This diagram shows the role of next-generation sequencing, or NGS. It allows a single visual phenotype to be sorted into its actual genetic categories: ADPKD, NPHP, ARPKD, or HNF1B, each of which requires a different clinical strategy. This genetic clarity determines a patient's entire lifetime of monitoring, from tracking portal hypertension in ARPKD to screening for intracerebral aneurysms in ADPKD. Precision nephrology combines three essential pillars: defining the molecular defect at birth via NGS, maintaining strict dietary metabolic control, and utilizing the latest KDIGO-approved pharmacology to delay the need for dialysis.